All right, great. I think we are ready to start. Like I said before the join, welcome guys to 2026. This is our first meeting of the year. I hope you all enjoyed your festive season and we are recharged for the new year. Dr. Musana, who is a registrar attached to Fita Medicine, will be presenting today on a case they experienced during their attachment to Fita Medicine. So as always, allow her to present, then critically comment in a way to improve. Yeah, so I think I'll give time to her. I'll make some few announcements at the end after the presentation. So please go on, Dr. Musana, present the case. Thank you.
Thank you so much, Dr. Verenga. Good morning, everyone, and compliments of the new year. I'll be presenting a case titled The Double Bubble in Utero. This was a case of duodenal atresia in Trisomy 21. So I'm presenting a case of a 27-year-old who was in a second pregnancy. At 32 weeks, the first pregnancy was uneventful. She was referred from a local clinic with a diagnosis with polyhydramnios that was noted on an ultrasound scan that had been done. This was almost 3 months prior. And she was complaining of low abdominal pain and backache, and also was admitted with an impression of query UTI. She reported to not be perceiving fetal movements. Her pregnancy was booked late at 31 weeks and 5 days, which was 2 days prior to us seeing the patient. And she had only had that one visit. HIV test was negative. Syphilis had not yet been done. She had no symptoms of hyperglycemia, and she had not been screened for diabetes. And due to her late booking, she also had no prior aneuploidy screening, and no fetal anatomy survey had been done. Her first pregnancy was in 2023. She had a normal vaginal delivery. The baby was 2,800 grams birth weight. There were no complications, and also there were no fetal anomalies noted. When she was admitted, of notice that fetal parts were not palpable. The height of fundus was large for gestational age at 41 centimeters, and the fetal heart was not audible by fetoscope. When they examined her, they noticed she was 3 centimeters dilated. However, there was no show. They were querying preterm labor and also a UTI. She was to commence dexamethasone course and was sent to us in the FMU for an ultrasound scan. So day 2 post-admission, her query preterm labor had not progressed. The ultrasound scan that was done, the routine scan that was done, showed a singleton live fetus that was in cephalic presentation. The estimated fetal weight was 1,734 grams, and this was appropriate for the gestational age. The single deepest pool, however, was at 145 millimeters, confirming the polyhydramnios, and she had abnormal Dopplers with a reduced end-diastolic flow in the umbilical artery, redistribution in the middle-cerebral artery, and they noted notching in the uterine artery. Recommendations at this point were for an oral glucose tolerance test, a torch screen, and also to be reviewed in the specialist clinic. In the specialist clinic the next day, the ultrasound scan noted a single live fetus, cephalic presentation. The placenta was anterior high. In terms of biometry, head circumference, abdominal circumference, and the femur length, they were all below the 10th centile, which was small for gestational age. And the estimated fetal weight was 1,500 grams at the 7th percentile, which was small for gestational age. And then the fetal Dopplers noted reduced end-diastolic flow in the umbilical artery with a normal MCA and reduced A wave in the ductus venosus, with notching confirmed again in the left uterine artery. In terms of the imaging, of note is we noted that our patient had a double. Sorry, apologies for that. Okay, so I was trying to see if I can get my pointer, but I think I'm failing to do so. But on the images on the left, we can see the typical double bubble sign, which is pathognomic of duodenal atresia with a distended stomach and also distended duodenum in that area of stenosis there that's in the midline between the two asterisks 1 and 2. And then on the diagram on the left is just also confirming that area of atresia with that typical double bubble sign that we note for patients with duodenal atresia. This next image is that's just an image that's just confirming our single deepest pool, which you know there was quite a bit of amniotic fluid there, and the deepest pool was around 180 millimeters. Due to the duodenal atresia that was initially noted, we then went on to look for other congenital anomalies with a syndromic approach to see if there are any other associated congenital anomalies that might be found in this fetus. So on a survey of the heart, we noted that she had a submembranous inlet ventricular septal defect. On the diagram on the left, that is the distance that is recorded by the calipers there at 1, which was around 9 millimeters. And on the diagram on the right, with introduction of Doppler, we can see the blood flowing from the left side of the ventricle into the right side of the ventricle there, right ventricle. And then this next image is just showing that we also had absence of the nasal bone, which is also pathognomic of trisomy 21 syndrome. So after this ultrasound scan, due to the patient's discomfort, we then offered amnio reduction, which was done. We drained about 3,400 ml of amniotic fluid, and 20 ml of the sample was taken for karyotyping. However, our patient developed antepartum hemorrhage about 30 minutes after the procedure. She was sent to early labor ward and went on to actually deliver a live baby boy, APGAS 3 to 5 on 10. Birth weight was, the baby had a low birth weight of 1,600 grams, and blood loss was about 500 mils. And the baby was admitted into the neonatal unit. Images have been posted with consent from the mother. So this was a picture of the baby. So this is just an image showing the facial features which were pathognomic of trisomy 21. So our patient had a short nasal bridge, epicanthal folds. I apologize, I can't get, I'm failing to get access to the pointer. But the baby also had a large tongue on opening the mouth. He also had a simian crease, which is a single palmar crease, and also lateral eyebrows and low set ears. In the postnatal period, the baby was admitted on maintenance fluids made up to ring as lactate with an NGT inserted. Our baby developed bilious vomiting and there was no passage of stool. Day 5, the pediatric surgeons took the baby for laparoscopic duodenostomy for duodenal atresia, which was successful. However, the baby did not do so well post-delivery. She was noted to be bleeding through the NGT tube and was in constant respiratory distress post-op, and unfortunately demised at 3 a.m. the next day. So that takes me to the end of my case presentation. Over to you, Dr. Verenga.
Thank you so much, Doc. I think we'll open the room for questions on the case presented. Please go on and ask questions to the presenter. I don't see. Okay, Dr. Madimbo, please go ahead, Shemba.
Okay, thank you very much, Dr. Musana, for beautiful presentation. The diagnosis of trisomy 21, did we receive the karyotype results? Is it a clinical diagnosis? Thank you.
Thank you so much, Dr. Madembo. So after delivery of the baby, we had made a decision that they would do, instead of taking the amniotic fluid for a karyotyping, they would sample the baby. However, the baby then demised before they could do that karyotyping. So we never really got any karyotyping results. It was all just based on a syndromic approach and the typical features of trisomy 21.
Okay. Do you have another other question? So what are the differential diagnoses? If with the same image, what else could this be mistaken for? I mean, just for ultrasound scan students, so that everything will not become duodenal atresia.
Thank you so much, Dr. Verenga. So in terms of differential diagnosis, there's definitely a couple of number of things that can mimic the double bubble sign, giving us false positive cases. So these can be your foregut duplication cysts. You can also have choledochal cysts. This can also be duplication, intestinal duplication, and also what are known as lad bends. That's in the case of malrotation of the foregut. And also in females, you can also note ovarian cysts.
Thank you. We may continue this discussion. Then if there are any questions, please read them in the chat box or right at the end. Thank you.
Thank you. So for our discussion of this case, duodenal atresia, it's one of the significant causes of neonatal intestinal obstruction, and it occurs in 1 in 5,000 births. However, in those patients with duodenal atresia, it can be associated with chromosomal abnormalities, especially trisomy 21, as was in our case, and this is in 25 to 30% of the cases. So this is just saying in all patients that have duodenal atresia, 25 to 30% of them will have Down syndrome. And the global pooled prevalence of duodenal atresia in the patients with Down syndrome is 3%. But there was no gender variation that was noted in the prevalence. So for my discussion, I'm going to zone in on this association with other congenital anomalies and also with trisomy 21, focusing on outcomes and management options. So duodenal atresia can occur as a solitary finding, in which case the risk of recurrence would be low. However, it's often associated with other congenital malformations in nearly 50% of the cases. So it's always important when you find it to screen for other anomalies, as we did for this patient, particularly the congenital heart defects, because there's an association in 20 to 30% of the cases, as well as other GI abnormalities. And these often determine the overall prognosis, the risk of recurrence, and also mortality, more than just a patient with atresia alone. So further investigations can also be done to characterize other defects, such as the fetal echo and also genetic testing, as we had offered our patient. When you look at outcomes of patients with duodenal atresia in the setting of trisomy 21, while isolated duodenal atresia cases actually have an excellent prognosis with prompt treatment and high survival rates of over 90%, the association with trisomy 21 and other anomalies tend to alter the survival rate. There have been single-center studies that were done and these have shown conflicting results on outcomes of duodenal atresia in those with and without trisomy 21. For instance, a study that was done in Thailand by Niramis et al., they did a retrospective review which showed that there was actually higher rates of post-op complications and mortality in the infants that had trisomy 21. And this was attributed to a higher incidence of the congenital heart defects and also recurrent respiratory infections. However, in infants with isolated duodenal atresia that were born at term, Prasad et al. Noted that the trisomy 21 diagnosis was actually an independent risk factor for mortality, with 3.27 times more relative risk. However, in comparison, another single center study that was done in the UK actually reported no differences in duodenal atresia outcomes. And they looked at the time to full enteric feeds, post-op complications, and mortality. So on this background of inconsistent single center studies, Bethel et al. Did a population-based UK study, which was comparing the impact of trisomy 21 on the duodenal atresia epidemiology, the management, and also the outcomes. And they found that of 102 infants who underwent repair, cardiac anomalies were, first of all, they were more common in the trisomy 21 cohort, but associated GI anomalies were less common. And they noted that there were actually no differences in the type of surgical management that was offered, which I think would be expected, and also the time to fill feeds, the repeat surgery, and also mortality. However, the patients who had trisomy 21 had a longer hospital stay of 23 days versus 16 days for the non-trisomy 21 infants. In terms of the role of early detection, Cohen Overbach noted that prenatal diagnosis resulted in earlier confirmation of the diagnosis and also more appropriate care post-delivery. However, those patients who had a prenatal diagnosis were tended to deliver earlier. I would attribute this to earlier recognition of other issues such as fetal growth restriction and also abnormal Dopplers with more prematurity and low birth weight. However, timely prenatal diagnosis still plays a critical role in enabling coordinated perinatal care and also providing prenatal counseling and prognosis to the intending parents. And this includes offering delivery at a specialized center that has immediate access to neonatal intensive care unit and also pediatric surgery. And this planned approach also helps to improve severe postnatal complications, such as electrolyte imbalances, aspiration pneumonia, nutritional deficiencies, which can arise from a delayed diagnosis. So these are patients who come in who are born with no prenatal diagnosis and only discovered after developing complications post-delivery. For management and prognosis, studies have shown no differences in the surgical management of patients with or without trisomy 21. So as for our patients, they went through the typical duodenostomy for the repair. However, there is need for planned postnatal management strategy that addresses all facets of the patient's condition. This includes timely surgical intervention within 24 to 48 hours of birth, once the neonate is stable, and also in those with other congenital malformations, a multidisciplinary team would be required to comprehensively manage the patient. And also postnatal parental psychosocial support should also be provided. So in my conclusion, prenatal diagnosis of congenital anomalies with thorough screening for associated syndromes is pivotal in providing quick and comprehensive postnatal care, and also with added emphasis on prenatal counseling and prognosticating, especially for the parents. This takes me to the end of my presentation. Thank you. These are my references. Over to you, Dr. Verenga.
Thank you so much, Doc. Thank you. Let's attend to questions in the chat box first before we give the participants to ask oral questions. How much fluid can be safely drained during amnioreduction to reduce risk of complication, like in this case? Is there a formula to determine target volume to drain? Good question asked. Would you want to attempt this question to say how much fluid should be drained?
Not at this moment, Dr. Verenga. I stand guided on this one.
Okay. The second one, were steroids administered? Could a APH have been an abruptio following amnioreduction? And could a cesarean section have improved the neonatal outcomes? Those are the questions.
Okay, thank you so much. For this one, we did have a concern for an abruptio, given the commencement of the antepartum hemorrhage post drainage, and also I think in retrospect now, I think the patient was already in labor. We had done a transvaginal ultrasound scan to check the cervical length, which noted that it was closed, but maybe this was an observer error because our patient then went on to quickly deliver within an hour post the procedure. And her estimated blood loss was about 500 mils. However, she was hemodynamically unstable post the delivery and even in the intrapartum period just before delivery. So there was definitely a concern for an abruptio. They did not note a retroplacental clot. However, it might have happened too quickly for us to have noted a retroplacental clot. In terms of a cesarean section, improving outcomes, I would say I don't think it would have made a difference in this patient given the quick progress of her labor. However, perhaps if it had been offered prior, given our patient before we even went for the second ultrasound scan, we had noted that there was fetal growth restriction. In the specialist scan, there was fetal growth restriction, and we also had already had changes in the ductus venosus. Perhaps a cesarean section would have been beneficial for the patient instead of going through the trauma of contractions and labor. However, I don't think it might have been done realistically given the time frame from onset of strong contractions to her delivery. Thank you.
All things being equal, I'll come back and reflect on the questions as well. But let's continue because there are some questions in the chat. All things being equal, what's your timing and mode of delivery for cases of duodenal atresia with or without trisomy 21?
Thank you so much for the question. So for our patients who have duodenal atresia, these are patients that ideally want to deliver within the 38 to 39 week time frame. And so these are patients that can be offered a normal vaginal delivery, given all things equal, meaning we have no evidence of fetal growth restriction and there are no abnormal Dopplers. They can still be delivered normally with immediate post-op care by the pediatric surgeons and also their neonatologists. However, in the setting where we have compromise of the fetus, then we would need to offer cesarean section.
Yeah, I think the questions are well answered, but maybe I'll just also reflect on the case to say, on reflection, of course, there were some learning points. We noted that this woman's cervix at some point was reported when we reflected on the notes that her cervix was already 2 centimeters, I think, when she came to us.
Yes.
Yeah, she was already in some form of labor, so we think probably the amniote reduction may have exacerbated the situation. A member of our team assessed the cervix, but we are now questioning that probably due diligence was not applied to checking the cervix. So we've put in measures now for the future to make sure that these kind of procedures are done diligently to make sure there's no over-reporting of what the cervix was, because certainly the cervix, I think, was already open. This explains the whole process. While abruption is reported as a complication of amniotic drainage, is very rare. I want to ascribe the bleeding to preterm birth. Say probably is somebody who just had a heavy show, and also 500 mils of bleeding is probably within what we'd call probably a normal expected amount of bleeding for somebody who has had vaginal delivery. Then in terms of a formula, there is no formula. The whole goal of amniotic drainage is to try and achieve to relieve maternal discomfort. To drain as much as possible, but on reflection on the case, at first we wanted to drain 2,000, but when you go to 2,000, there were still loads and loads of fluid. And our hope was that she was going to get to 38 weeks. So we thought if we left all that fluid, we could need to drain again the week after, where the discomfort would certainly come back quicker. So it ended up draining more because we wanted to achieve maximum maternal relief, because she was really tense and having difficulties in sleeping and so forth and so forth. And the husband, he said, it also had enough of the troubles at home. So yeah, so there's no definite formula, because quantification of the actual fluid, say how much is in there, is extremely difficult, because the amount of fluid inside a woman's tummy vary, one by gestation, two by the woman's size and habitats, because it's extremely difficult to know the quantity, except that we subjectively assess using the deepest pool whenever we measure the fluid, the single deepest pool. So I think that's my reflection on the case on the. I think there's something. Okay, I think Dr. Musana answered all Dr. Madembo's question to say when should we take out baby's defects? Generally, baby's defects, if everything is stable, should be taken out around 38 weeks. So that's the perfect time to take them out. And this should be done electively so that all the important people are around who can look after the baby after birth. So that's the ideal timing for babies with defects. Yeah, so for this particular case, I think the learning points is to do with prenatal screening. To say, I think our women should have early prenatal screening, and aneuploid screening should be offered to all couples. Dr. Musana, if you could just remind us, how old was this lady when she came to us?
She was 27.
Yeah, she's just a 27-year-old lady. And her pregnancy was looked after, but she didn't go for aneuploid screening, which could have happened at 12 weeks and probably help in identifying trisomy 21. Duodenal atresia is a condition that can be diagnosed from 24 weeks onwards. So it is normal that women who are not screened for aneuploid may have normal ultrasound fetal anomaly scans if they have duodenal atresia. So just be aware of this, that a woman with duodenal atresia is likely to have a normal fetal anomaly scan done between 20 to 22 weeks or 18 to 22 weeks, because duodenal atresia will manifest later. The same with polyhydramnios. Polyhydramnios will pop in later after 25 weeks. So prenatal screening has to start at 12 weeks, where women are offered aneuploid screening so that there is early detection of these cases and probably early surveillance and early diagnosis. But picking up things at 32 weeks is not the ideal antenatal care that the woman of Zimbabwe should receive, because it's quite traumatic. The journey is predicted from our side. We appreciate it's unfortunate they couldn't be here. They want physical meetings. The pediatric surgical colleagues, we had invited them, but they said they want physical meetings. They don't want the online meetings. So that makes it difficult. But it's unfortunate that they do their best, but sometimes in the presence of trisomy 21 and a heart defect, from our side, we'll be saying this case doesn't have a good long-term outcome, and all the effort put by colleagues in operating, I understand the operation took something like 3 hours to just try and correct the duodenal atresia. All these efforts, sometimes they could be prevented if early diagnosis was done, because the couple were amenable to termination of pregnancy if trisomy 21 was confirmed. So yeah, so I think that's my reflection and comment on the case. Maybe we'll open the room for any comments or for any views on this case, especially how the case was managed. If you think we should have done better, please raise that and say, why did we do A, B, C, D? I think that I don't see any comments. Yes, Dr. Mkono Shuro.
Thank you, Doc.
I can see
I just wanted to find out, what would we have done differently if we had diagnosed it early? Would we have offered the termination?
Yes, for trisomy 21, yes.
Okay.
For trisomy 21 is a condition that causes severe physical and mental handicap. So under the Pregnancy Termination Act, if the baby the woman is carrying as a condition that may cause severe physical or mental handicap, there are legal basis to offer this woman termination of pregnancy. Even at 32 weeks, if we had succeeded in doing the amnio, which the couple had opted in to do, and proven that it's trisomy 21, termination of pregnancy was still an option for this couple. But in this case, we would have to do fetal side first. But it was still going to be an option for trisomy 21. But duodenal atresia on its own is a solitary condition. It's not a condition I would say it's not a direct condition for termination, because it's something that can be repaired successfully. So duodenal atresia on its own, we do not routinely offer termination of pregnancy as an option to couples, because this is amenable to surgery with good outcomes in isolated cases.
Thank you.
You're welcome, Doc. Do you have any questions? So if we do not have any questions, thank you so much for taking time to join. I just have some few announcements to make, or some few changes that you may see. I think in the unit, Dr. Musara will be partly doing a senior reg with us in the fetal medicine unit. So she will be coordinating some of the activities like these meetings now, and also trying to raise some audit files where we'll be auditing cases. So she will be working together with the registrars that will be rotating and with us. You have also noted that Dr. Munya Rutsate is